Here to discuss all of it with me is Dr. Meena Seshamani, head of Medicare. Dr. Seshamani, really a really active morning for you, I'm sure. A lot going on in the discussions around what happens next and the drugs that were in fact selected. So let's start off with the what happens next. You have a little bit of a breather between now and when negotiations start. Talk to us about what's going to happen. What are the next steps?
Absolutely. And thanks for having me, Anjali. So today we released the 10 drugs that have been selected for negotiation. The next step is on October 1st. The manufacturers can decide whether they want to participate in the negotiation process. October 2nd is when we will get data that we will use for this negotiation. We will then engage, have patient-focused listening sessions for each of the 10 drugs, meet with each of the manufacturers, and then enter the negotiation process with an initial offer. All of this is laid out in the Inflation Reduction Act law and in the guidance that we put out. So on February 1st, we will put out our initial offer to the manufacturers. According to the Inflation Reduction Act law, they have about 30 days to provide a counter offer if they do not agree with that offer, or to accept that initial offer. If with the counter offer that CMS doesn't agree, then we will engage in up to 3 negotiation meetings for that back and forth, ultimately leading to a final agreed maximum fair price that will be published on September 1st, 2024. And we will also then subsequently publish a narrative about that entire negotiation process.
I know that some of the companies have already filed suit trying to delay or stop the process altogether. And in their lawsuits, some have said that they're worried about what that maximum fair price is going to be and that it could, quote, be as low as a penny. And so I wonder what your thoughts are on that and how, if you could explain how Medicare is going about deciding what the bar is for an appropriate cost.
Yes, I think we all have shared goals that we want to improve access and affordability for the innovative therapies that people need. And as we laid out in our negotiation guidance, we want to be able to look at the benefits that a drug brings to populations. Does it address an unmet need? Does it address different populations that have needs? Can we look at things like being able to live at home and not be hospitalized, and to be able to incorporate all of that into an agreed upon fair price for the Medicare program for all of the people who rely on these often life-saving medications and for the American taxpayer. And so that is how we will approach this in a true back and forth negotiation process.
I know some of the drugs that were listed caught some by surprise, some expected like Eliquis, but then Stelara, I know a couple of reporters have already asked about the fact that they may be facing generic competition, as well as the insulin because of that out-of-pocket cap already in place. Can you explain why some of these drugs made it and whether or not the list could potentially change before 2026?
The list of drugs that have been selected will not change. Those are the selected drugs. How we came to that selection was following the new drug law, what is written in the law, where first we looked at the 7,500 drugs that are covered in the Part D Medicare program and looked at which ones are what are called in the law qualifying single source drugs, meaning that they are drugs that have been on the market for 7 years for a drug product, 11 years for a biological product, and do not have competition. From there, again, following what is in the law, we excluded drugs with low Medicare spend, plasma-derived products, certain orphan drugs. We also got information from manufacturers for a small biotech exemption. Again, that is laid out in the law. And then also looked at whether for biosimilar manufacturers, they could submit a request to us for a potential delay, if there's a biosimilar coming on the market. Again, that is laid out in the law, and all of this is also put in detail in the guidance that we put out. Once we went through all of these criteria, we ranked and basically have the top 10 drugs in highest gross spend. So all of the drugs that are listed are ones that met all of those criteria.
Now, tell me about these companies that were selected. I know that, the administration chose to release this list before the opening bell, and it hasn't really seemed to make an impact on the stocks right now. Do you see that as a sign that they are not really going to be impacted negatively by these negotiations?
Well, I think we know that the pharmaceutical industry is strong and thriving, and innovates and will continue to innovate. And in fact, the way that we have laid out, as we were talking about, Anjali, this negotiation process, it really is with an eye towards how do we reward the innovations for the cures and therapies that people need? How can we incorporate real world evidence for these drugs that have been out there being utilized to understand what impact they have in the real world for real people, so that we can take that into consideration as we look at what a price should be for these kinds of medications. And I think that's what you're seeing.
And I know that the fines are going to be put in place for those companies that decide not to participate or who don't want to participate in the negotiation process. What then happens with this list, and what happens to those companies? Is it, a fine in perpetuity, or is there an endpoint?
Yeah, so there is an excise tax that is operated by the Treasury Department, by the IRS. If a company decides not to participate, in the negotiation process, as you described, we laid out in the guidance where, if there are ways that a company cannot have that excise tax, where they can, negotiate and come to an agreed upon maximum fair price, or they can exit the Medicare and Medicaid market. And the details of that are in the guidance. In terms of the drugs, if a company does decide to come back and participate in the negotiation process, we have laid out in our guidance that we will engage, we will, use the same process that we are laying out now if a company comes back at a later point. And also in the guidance, we lay out that we will continue to monitor for competition for these drugs. There are ways in which, again, laid out in the law and in our guidance, where a drug that is selected may not have the negotiation if they meet certain criteria that have been laid out.
Well, certainly leaving that open door policy, as companies are familiar with, we'll have to leave it there, but certainly a lot more work for you yet to do. Dr. Meena Seshamani, head of Medicare, thank you so much for joining us today.
Thank you for having me.